معذرة على this technical problem. Now I'm going just to talk about management of focal segmental glomerulosclerosis. This is my agenda. I'm just going to briefly talk about focal segmental introduction, prognostic factors, response to therapy, and overall approach to therapy, non-immunosuppressive medications and immunosuppressive medication, and other new modalities for management of focal segmentals. And I will finish by take-home message and conclusion. Focal segmental glomerulosclerosis, as we know, is a morphologic pattern of glomerular injury primarily directed at the glomerular visceral epithelial cells, and it may be idiopathic in most of the cases, and it may be secondary in some cases, as Dr. Sosan just was talking now. Primary focal segmental glomerulosclerosis can present acutely with an overt nephrotic syndrome characterized by hypoalbuminemia and edema. On the other hand, secondary focal segmental glomerulosclerosis often presented as asymptomatic proteinuria without a profound hypoalbuminemia or edema. And to differentiate between primary and secondary focal segmental disease is particularly important because the treatment is totally different in both. Primary focal segmental glomerulosclerosis is often responsive to treatment with glucocorticoid and immunosuppressive medications, while the secondary focal segmental glomerulosclerosis usually responds to the non-immunologic medications. These are the different causes of focal segmental glomerulosclerosis, either viral disease, drugs, genetic mutations, and some adaptive and structural changes in the glomeruli, including reflux, glomerulopathy, hypertension in some cases, diabetes, obesity, and sickle cell disease. And these are the different pathologic patterns. I'm just going to skip these points. Dr. Sausan, I think she talked extensively about them. So just to remind you, the focal segmental, non-otherwise specified or perihilar variant, or cellular variant, or collapsing variant, and focal segmental tip lesion. And these are the prognostic variables that determine the fate of focal segmental glomerulosclerosis. The degree of proteinuria, the worse the proteinuria, the worse the prognosis, and the severity of the renal dysfunction. Also, upon the presentation, when the patient is presented with decline in the GFR, the prognosis, of course, is going to be worse. And according to the histologic pattern also, the collapsing pattern is the worst one among the different pathologic terms of focal segmental glomerulosclerosis. Regarding the response to therapy, just few terms you should know. I think all of you, I think, are just aware about it. In terms of complete remission, what does it mean? It means that the patient got respond with a reduction of the proteinuria less than 300 milligram per day, or partial response, the patient came down beyond or less than 3.5 gram per 24 hours, or a relapse means that return of proteinuria to more than nephrotic range 3.5 gram per day, and someone who was already responsive and got remission, either complete or partial. Steroid dependence, the patient is going to be dependent on the steroid. Once you decline the dose, the patient may get relapse again, or may have some deterioration of the kidney and the proteinuria. And the patient with resistant proteinuria, this is a patient who never developed improvement in terms of partial or complete remission upon initiation of treatment. And the percentage of event-free patient among those patients who either remission or non-remission, of course, the patient who gets remit earlier, the frequency of relapse or non-responding is going to be just minimal in comparison to those who didn't respond from the start. And this data from the KDIGO just show just very outlines or just highlighting or shedding the light on the management of patient with focal segmental and patient with histologic evidence of primary focal segmental glomerulosclerosis who have nephrotic syndrome are usually offered a disease-modifying agent with glucocorticoid or immunosuppressive medication. And they just recommended that to provide such treatment in patients with primary focal segmental glomerulosclerosis with nephrotic range proteinuria more than 3.5. While those patients with non-nephrotic range proteinuria less than 3.5 gram, these patients may be considered as those who are secondary and usually respond to other modalities rather than immunosuppressive medication or glucocorticoid. Again, patients, they just offered, recommended again that glucocorticoid and other immunosuppressive medication are not initiated in patients who do not have nephrotic syndrome, as I mentioned earlier. And again, they mentioned we do not usually initiate such treatment in patients with histologic evidence of extensive glomerulosclerosis or interstitial fibrosis. It's very important the patient who have, for example, tubular atrophy for more than 30%, or extensive glomerulosclerosis, or who have interstitial fibrosis, the role of glucocorticoid or other immunosuppressive medication is going to be very minimal in those patients. And now I'm just going to talk about the non-immunosuppressive therapy for patients with focal segmental glomerulosclerosis. These medications that we just define as antiproteinuric drugs, for example, ACE inhibitors. This is one of the most, ACE or ARBs, in actual fact. And these are the two main non-immunologic immunosuppressive therapy should be instituted, either ACE or ARBs or lipid lowering medication. Let's start with ACE inhibitors or ARBs. ACE or ARBs should be given to all patients with primary focal segmental glomerulosclerosis, such as a specific immunosuppressive treatment is undertaken, or primary therapy for patients with non-nephrotic range proteinuria, who are usually secondary focal segmental, or patients who are not receiving immunosuppression for a reason or the other, like those who are just suffering from extensive fibrosis or interstitial fibrosis or glomerulosclerosis. ACE inhibitors reduce the proteinuria in patients with primary or secondary focal segmental, but rarely induce remission without immunosuppressive treatment. In addition, these drugs slow the rate of the progression to kidney disease, like other chronic kidney disease. ACE or ARBs just do so in the same, to the same degree in patients with focal segmental by reducing or slowing the progression of chronic kidney disease or focal segmental glomerulosclerosis. And this study on enalapril showed that enalapril improved renal function. It's an old study, but yeah, it shows the role of ACE. And I think another study is talking about ARBs also, showing the benefit of ACE inhibitors in progression or slowing the progression of the proteinuria and slows the decline in the GFR in patients with focal segmental glomerulosclerosis. Showing this data showing that the proteinuria is getting improved here. There is no pointer. It's okay. It's showing here the proteinuria is getting improved in patients receiving the arm of enalapril, and similarly on the line of the second line, it shows also that the creatinine is getting improved. And they concluded that, thank you so much. They concluded that enalapril therapy may improve the progression in glomerulosclerosis or maintaining the GFR or even improve the GFR. The role of lipid lowering agent has been studied and just in many researches, and just to know hyperlipidemia with often dramatic elevation in the serum cholesterol. This is a typical scenario that we have in patients with nephrotic syndrome due to a reason that you all know, hypoalbuminemia, with compensatory increase of the lipid just to carry the function of the albumin, is well known in patients with nephrotic syndrome, and similarly in patients with chronic kidney disease, and both of them are associated with, as you know, cardiovascular morbidity and mortality. Therefore, the role of lipid-lowering agent may have an impact in patients with focal segmental or nephrotic syndrome in general. And this data, a systematic review from Cochrane Library, it just studied the lipid-lowering agent for nephrotic syndrome, a review, and it showed that there is no enough evidence, or considerable high-quality evidence to just say that the lipid may have an impact in management or slowing the progression of focal segmental, like other all nephrotic syndromes. Now let's talk about the very important topic in my talk, which is immunosuppressive medications and its role in management of patients with chronic focal segmental glomerulosclerosis. And most of the patients initiating glucocorticoid are talking now about steroid, okay, which is the mainstay or cornerstone of management of different glomerulonephritis or nephrotic syndromes in general. And most of patients initiating glucocorticoid therapy for primary focal segmental glomerulosclerosis, we use prednisolone 1 milligram per kg with a maximum dose of 60 to 80 milligram per day, with subsequent tapering of the dose. If the patient is responding within 1 month or so, you're just getting to extend the dose for another 2 weeks or something, then you taper the medication over a period of 1 or 2 or 3 months. Okay? Depending upon the response to the and the toxicity of this therapy, the duration of the prednisolone may vary according to the response, from 8 to 12 weeks, as long as maybe 1 year or something. If the patient is having a complete remission, okay, within 8 to 12 weeks, as I mentioned, we continue the initial response of the dose of prednisolone for another 1 or 2 weeks, then we taper over 3 months. If there is partial response, okay, with more than 50% of the initial proteinuria or less than 3.5 gram, okay, the remission or the partial remission achieved by 12 weeks, we taper over 9 months, okay, we taper over a long period actually just to maintain this even partial remission. For patient, what we should do for duration and monitoring of patient with glucocorticoid, complete or partial remission after it's been attained, proteinuria increase while the prednisone is tapered, then we stop this dose that we reached upon and we initiate again from the far beginning. For example, if you start by 80 milligram and the patient upon tapering started to get relapse or whatever again, then we resume the initial dose, and for the period that it's assumed, for example 12 weeks or more, then we taper again. And these are the factors associated with lower response to glucocorticoid, as I mentioned earlier, like other immunosuppressant, significant tubulointerstitial disease, massive proteinuria, more than 10 gram per day. Sometimes they call it malignant proteinuria, or more than 14 gram per day. They call it like that, malignant proteinuria. Or not malignant as malignant, and just by kind of it's going to be extensive or massive proteinuria. Steroid resistant in the presence is present in some of the familial forms of the focal segmental glomerulosclerosis, and it's been associated with mutation of some gene. And these are just studies just talking about the factors associated with poor response to patient with focal segmental, massive proteinuria. And they concluded that, as I mentioned earlier, the degree of proteinuria at presentation consistently has been prognostic significance. Is more than 10 milligram or 14 gram per 24 hour, it's associated with poor response and even progress to end-stage renal disease. And similarly, also they are talking about the patient who are responding or not responding. Initially, the prognosis also depends upon the initial response. And now I'm going to talk about the other immunosuppressive medication, and let's start with calcineurin inhibitor as an alternative initial therapy. It may be, but usually you start with steroid. However, in patients with at increased risk for glucocorticoid toxicity, for example, those with obesity, for example, diabetic patient, and with severe osteoporosis and elderly, this patient may get benefit from other immunosuppressive medication like cyclosporin or tacrolimus with or without low dose of steroid. And calcineurin inhibitor is avoided or contraindicated in patients with vascular or interstitial disease or with GFR less than 30 milliliter per minute upon presentation because of its well-known nephrotoxicity. And this data is just talking about the treatment of focal and segmental glomerulosclerosis in adult with tacrolimus monotherapy. Thus, this study showed that the benefit of improving at follow-up of the proteinuria in terms of remission. Okay, this mentions that clearly that TAC appears to be an effective treatment in focal segmental glomerulosclerosis, and the effect of TAC on renal function in this study actually was just carried out in very few number of patients, and they concluded that it should be carried out on a large scale of patients to see if the real response of focal segmental is to be considered in patients taking tacrolimus. And similarly, cyclosporin. If cyclosporin is used according to KDIGO, they mentioned that to start with 2 to 4 milligram per day, given in 2 divided doses, with cyclosporin trough level to be between 100 and 170 nanogram per ml. And if tacrolimus is to be used, they start with 0.1 milligram per kg per day, given in 2 divided doses, also with a trough level of tacrolimus from 5 to 10 nanogram per ml. As with cyclosporin, the dose may be needed to be adjusted depending upon the clinical response and the trough level. This medication actually, this slide actually is very important because we're talking about the duration of medication. CNIs to be continued at least 6 months following attainment of complete remission and 1 year following attainment of partial response or partial remission. And due to the concern of acute nephrotoxicity and hyperkalemia, it's better to measure the serum creatinine and potassium in patients receiving these 2 medications. And thereafter, the serum creatinine, electrolyte, fasting blood sugar, and urine PCR ratio at least every month or 2 weeks in patients receiving such medication after attainment of remission. How about those patients who are relapser after a long time of complete or partial remission? In patients who are previously had complete or partial remission with glucocorticoid who didn't have significant side effect, has not developed a condition that increased the risk of glucocorticoid nephrotoxicity, and has been in a remission for a long period, more than 2 months. Okay, after discontinuation of the steroid, we assume to restart or to repeat the medication again. If the patient had significant glucocorticoid and whatever, okay, it's better to start with another medication if the patient didn't get the initial response. For example, with CNI, with or without low dose of steroid, provided, as I mentioned earlier, the GFR is more than 30 milliliter per minute. Or if there is any contraindication or some nephrotoxicity with CNI, we advise to start with MMF as an alternative to the CNI with, combined with low-dose glucocorticoid. Treatment of patients with steroid dependent or steroid resistant, I think we're going to start with CNI or MMF, and this is like the same scenarios that I mentioned. Bearing in mind there is no evidence of decline of the GFR, of evidence of interstitial fibrosis or extensive glomerulosclerosis, or to use the newer medication like rituximab or cytotoxic T lymphocyte E4 and inhibitors. And this data talking about the management of patients, it was one of the randomized trial of cyclosporine in patients with steroid resistant and steroid focal segmental glomerulosclerosis. It's mentioned here, it is very clear here that the patient was free of relapses or the stops of decline of the GFR or proteinuria is much better in patients who are receiving cyclosporine in comparison to the placebo. And the conclusion here was that cyclosporine is an effective therapeutic agent in the treatment of steroid-resistant cases of focal segmental glomerulosclerosis. And similarly, tacrolimus also, but they mentioned very clearly they need a large randomized study to test the effect of the tacrolimus in patients with, however, it's one of the best alternative in patients with focal segmental either dependent or resistant nephrotic syndrome. And the role of mycophenolate mofetil also in the treatment of focal segmental glomerulosclerosis has been studied, and the conclusion was MMF appears safe to use in patients with resistant or dependent nephrotic syndrome, and they are not they are contraindicated for other modalities like CNIs, tacrolimus, or focal segmental. And this study was also carried on a small scale of patients, and they recommended also to be carried on large or wide scale of patients. And the other therapeutic, it's not new anymore. It was just well-known medication, like, for example, rituximab for management in patients with steroid dependent rather than steroid resistant. For patients who are resistant, their chance to get benefit from rituximab is just considered very minimal. So if you like to go for rituximab for patients with focal segmental glomerulosclerosis, you just start earlier in patients who are either dependent, or if you have the money, you can start early without, just knowing that it's steroid dependent or even resistant. And this data for rituximab, they are just talking about management of 8 patients with steroid resistant. Only 3 of them got responded to rituximab, and they mentioned that for patients who are steroid resistant, not to be tested for rituximab. I think almost the same scenario. These 2 studies, one of them are the same study actually, are just 4 patients. 2 of them were steroid dependent and 2 were steroid resistant. The 2 steroid dependent who were responding, but the others steroid resistant did not. And other modality of medicine of therapy is the plasmapheresis or apheresis and related modalities based upon very limited experience according to KDIGO. They consider plasmapheresis in patients with primary focal segmental glomerulosclerosis in the following conditions, like patients with severe disease manifestation despite an adequate trial of initial immunosuppressive medication in which very high level of circulating permeability factors are there. And the patient with continued massive, as that I mentioned earlier, malignant proteinuria with proteinuria more than 10 grams or 14 grams per day, or suffering severe hypoalbuminemia despite exposure to an adequate course of prednisolone or cyclosporine or MMF. And lastly, the recurrent FSGS in patient with transplant. Just is one of the hyperacute rejection actually in transplant, and this is one of the indication of plasmapheresis in those patients. And this study actually also mentioned clearly that the plasmapheresis may diminish proteinuria and stabilize renal function in a small minority of patients، ولكن لا تعمم يعني كواحدة من ضمن الموداليتي اوف تريتمنت إلا في الظروف اللي احنا قلنا عليها، وطبعا بيزد على حتى الكيديجو نفسهم يقولوا ان their experience is very limited in that issue. And this study also, just although it is done in a small number of patients, but it's diminished, but it's going to be not the main line of treatment in patients with steroid dependent or resistant nephrotic syndrome. And the newer agent like co-stimulatory inhibition, abatacept or CTLA4 inhibitors, they are just tested here in this study, and they mentioned that in very few cases it may induce remission in patients with focal segmental glomerulosclerosis. And the last modality of medication, which is LDL apheresis, and it's very small randomized clinical studies using this variable schedule for low-density lipoprotein apheresis in patients with steroid-resistant focal segmental glomerulosclerosis have demonstrated some benefit in patients with in terms of reduction of proteinuria and improving the serum albumin. And this study, as I mentioned, just for using the LDL apheresis, should be used earlier. I mean, bardo, it is the same. If you use it later in patients with resistant and those suffering from long-term complications, I think the benefit is going to be very minimal in those patients. So you use it like other modalities of medication as early as possible. Once it's resistance, means it's resistant. Okay, I think I just want. I came to my conclusion, Mr. Chairman, and sorry if I just got 1 minute extra, Dr. Hussein. The use of ACE inhibitors or ARBs along with the good blood pressure control should be one of the main modality for management of patients with focal segmental glomerulosclerosis. And in nephrotic patient with primary focal segmental, there is recent evidence that using of immunosuppressive medication in treating such a patient is very important. Keeping in mind also the glucocorticoid should be kept as a cornerstone and for initiation of treatment of those patients. In patients showing a response to treatment, the dose can be slowly tapered over additional 3 months. For patients unresponsive to initial course of therapy, a more rapid taper over, for example, 4 weeks should be utilized to minimize the further steroid exposure. And in relapsing patient or steroid dependent, 2 to 3 months extra for cytotoxic agents like cyclosporin or other tacrolimus or MMF, or if there is contraindication to both, they can get benefit of this medication. And in patients who are steroid resistant, CNI appears to have a better overall response rate than the other cytotoxicity agent. And since the relapse is common after CNI, it should be discontinued in patients with suffering glomerulosclerosis or other toxicities like hyperkalemia and decline in the GFR. Thank you for your attention, and I'm ready for any questions.